So what's up, family? This is Otis Collier here, and I got a banger for you. So you ever had questions on how to progress or regress certain exercises, or how to progress, regress certain conditions or pathologies, or even how to approach them? Like, what's your plan? How do you do certain things? What makes you apply this exercise compared to the other one? How do you know the person is ready to actually move on or regress? Don't worry, I'm here to kind of clear that up. We're gonna crystallize that today. All right, so I'm starting a little series and sharing with you how I approach different medical conditions and pathologies and the people that I see. And we're gonna start with peripheral neuropathy. Okay, so all that means is that you are losing sensation in the extremities away from your spinal column. Okay, so just to give you a little recap of what this is. So your central nervous system is your spine and your brain, and your peripheral is everything else outside of that. Okay, so what I want you to do is lock in and get a pen and paper. I'm gonna break down how I approach peripheral neuropathy and also musculoskeletal pain. Okay, so before we get on to all that, I want you to like and subscribe. Leave things in the comment, ask questions so I know what you're thinking, so maybe I can answer them if you want. Or you can reach out to me any of my social media platforms. We can have a discussion. Tell me what you like, tell me what you dislike, tell me what you want to go over next, and I will gladly put it out there. All right, now that we got all that done, let me put this out here right now. This is my disclaimer. I am not a medical professional. I am not a physician. I'm not a chiropractor. I'm not a nurse practitioner. I'm no medical practitioner, okay? I am not here to diagnose anything, all right? I am not here to tell you how to treat, all right? My job here is an educational purpose and give you a little glimpse of how I approach certain things, all right? But if you have any signs, symptoms, please go reach out to your medical practitioner and let them handle it. I am not here to diagnose. I am not a medical professional. All right, now we got that out of the way. So we're talking about peripheral neuropathy, y'all. Okay, so this is actually a very common condition that we have right now. Most common one you notice is diabetic neuropathy. Basically, where people have type 2 diabetes, they lose sensation in their feet. All right, hence why they tell them to wear shoes or socks so they won't hurt themselves, they won't prick. Because when you have neuropathy, it's really hard for you to sense things, particularly the further away from your spine, the harder it is to sense. So your limbs is harder to sense than your sternum. Even going into your limbs, your fingertips is harder to sense versus your shoulders. So the further it is away from your midline, your spine, the harder it is for sensation. Okay. So what is neuropathy? All that means is that your nerve endings are starting to be damaged. Well, is the axon or is the myelin? All right. So we're not going to really get too deep into that. All right. So I'll put up another video somewhere up here, and I'll explain exactly, break down the nerves and how the anatomy of the nerves and what do they do, what each part, but that's for another video. So right now, we're going to get into how to treat peripheral neuropathy, all right? So we have three main points here that I'm going to try to cover as quick as possible, all right? I'm trying to time myself. Okay, the first one is addressing the monotonous programming for specifics when you're trying to progress or regress exercise. It's real wordy. In other words, how do you get out of giving everyone the same exercises, the same sets, everything is looking the same when you write it down in a document, everything looks the same. Session 1, session 5 looks the same exact way. All your neuropathy patients have the same exact exercise, the same exact program. And how do you learn how to progress and regress? So why is that important? That's important because when you document, when you send it to an insurance carrier, or you document, or you have your POC or POE, when you send it to the doctor, when you send it to the insurance, they're going to see it like, okay, you have to explain to me where's the progression, how are they getting better? The whole purpose of rehabilitation is to get them better. You must get them from point A to point B in a progressive manner, and you must show medical necessity, and you must show progression, all right, to get them back to their baseline functional level. So if everything is the same, how are they getting better? And more importantly, how are you medically necessary to do it? That's a key there, okay? You need to be medically necessary to do it, all right? if you're going to work with these type of population. If you're just doing regular people, okay, but in these medical condition population, you have to show your medical necessity in it. And having the same exercise is not going to work. So that is one. We're going to show you how to regress and progress quickly on that, okay? The second goal of this is when to use different intensities, when to use different types of modalities. Not necessarily modalities, I'm sorry, scratch that. Different types of intensities and different type of approaches for neuropathy, all right? When do you use low intensity? When do you use high intensity? When do you use speed strength? When do you use these different things? Okay, we're going to touch on that briefly. And the last one is, how does pain influence your approach in the treatment? When you're with these patients, it might be most likely you're going to have some kind of level of pain present. I'm not saying to directly address pain. If you can, you make sure you look up your state's regimen to see what you can and can't do legally based off your practice and occupation. All right, but most of us that are non-physicians or non-therapists or non-licensed people cannot address pain directly with hot packs or cold packs or any of those type of modalities, but you can still do exercise, and there are ways to introduce exercise to the person while still acknowledging their pain, okay? You're not treating, you're acknowledging their pain. That's a big key there, okay? So these are the 3 steps. So let's get into step 1. All right, so step 1 is breaking out of giving everyone the same old routine. How you progress them, how you regress them. So with any neuropathy patient, I always start with isometrics. You always start with isometrics. Why? It helps the person ramp up motor units. All that means is that when they're trying to effort and they don't have enough muscle to use it, they call on help. Okay, so let's use my hands. I got 5 helpers. All right, so the first task, whatever task I am, say I'm trying to pick up this book. All right, my thumb is not strong enough to pick a book. Okay, I'm trying. So I don't have enough strength. So what I do, I call on the motor units on the next finger to help me. Okay. And it keeps doing that. So say these 2 fingers don't have enough strength. So what it does, it calls on more motor units, it activates more motor units, and particularly another muscle. So each finger is a muscle to help on. And it constantly do that until it reaches up to 2 points. Whether it's 1, it has enough motor units and have enough strength and muscles on board to do said task, pick up paper, or it has recruited all the motor units it has within that region of muscles, and it can't move anymore. Okay, so these are isometrics. It's great to have isometrics because you're teaching the client how to recruit muscle units within that set task. Okay, that's very important. And once they're able to recruit that thing, now they're able to stabilize whatever they have. Okay, so I typically do this for, if they have ankles, we'll do that for ankles. We'll do that for wrists. These are the 2 common sprains you have. So you want to definitely incorporate isometrics in your treatment in the beginning. Okay, it's really key. Now, how do you know if this person can progress or you need to regress? Now, regression basically means is that you're doing passive range of motion and you're doing stretching. That's a passive range of motion, as an assistive range of motion, or anything like that. That's where you're basically doing it and they're just feeling it and you're trying to tell them to help you. Or you can progress it into something next is eccentric. Eccentric, scratch that. It's eccentric. You go from isometric to eccentric. All that means is now I call these the breaks. How well can the person control said movement and slowing it down? Okay, so you want to slow the movement down of lowering. So let's go back to the same example. All right, so now I isometrically holding the book, all right, but my hands are getting tired. Say my thumb is getting tired. How well can I slowly control it down to the ground, except for just dropping it? Okay, so that's eccentrics. It's basically the breaks, and you want to be able to see how well they control it. What is my standard of a person to kind of do it? The person needs to be able to do isometrics for approximately 60 to 70% effort. So they need to be trying about 60-70%, and they need to be able to hold it for 1 minute. If they can get through that through isometrics, then they go to eccentrics. And with eccentrics, my standards of progressing them to the next one is they need to be able to do 10 repetitions for approximately 10 seconds each rep. So that's about 100 seconds, somewhere in there, a minute, minute and a half, somewhere in there. If they can demonstrate that with full control and no compensation, then they can go to the next progression, which is concentric. Okay, so it goes from isometric, eccentric, concentric. Okay, so once you go through that, once you're at concentric, that is basically in the same example. Isometric is staying still, eccentric is slowly lowering it, isometric is how fast can I pick it up. Okay, I call that the gas. All right, so it's basically neutral, brakes, gas in an analogy of a car. So concentric is the stage where they now you're starting to build up strength. Now you're starting to move from being stable to now you're starting to lose dynamic strength. Okay, so that is really key. These are the ranges. These are the ranges where how I progress a person from beginning to the end, and is a continuum. All right, it's a continuum where I can scale it back and forth based on what the client is presenting in front of me at the particular time. All right, and I must put this key here: when you're doing concentric, eccentric, and isometric, it does not have to be heavy. This does not mean heavy. You can go a low intensity isometric for 2 minutes. All right, sounds crazy, but you can do it for 2 minutes, a minute and a half, where they're only doing about 30% effort. What you're kind of doing is you need to get these tissues to get used to this kind of strength. Okay, you can go to 50%. It can go 70%. If you want, you can go for 100%, but it won't last very long. That's really up to you and what you're trying to accomplish with set exercises. These are just frameworks for you to follow. Okay, boom. So that's one. So the second one, that is basically how to progress and regress. The second one is when to use low intensity, when to use high intensity, when to use certain things. So with neuropathy, you want to use low intensity first. Endurance is more important in the beginning than strength. Why? Because when neuropathy, your muscles are not contracting. What that means is that your joints are more lax, they're more vulnerable to injuries, and the tissues around it, the white tissues around said joint, is more going to compromise, which will cause some type of pain. So you want to slowly introduce certain force into this tissue to where it can handle it. Neuropathy, they're particularly if it's sensation or even motor. Okay, that's a different thing as well. So if it's sensation, they just can't. It's difficult from the feel. Okay, but if it's motor, they don't have any control over it. They're kind of paraplegic. All right, that means that these muscle units and these fibers have not been moving at all. All right, so now you're trying to contract hard. You're trying to get them to contract hard. You can put shear force in the joint and damage it. So you want low intensity. You need endurance more than strength. All right, and it also helps mitigate fatigue as well. So low intensity first. Low intensity, maybe 30% effort for how long? A minute, 2 minutes, something like that. They need that first. All right. Then you can segue into high intensity. All right, what that means is now you're going for more strength and endurance. So instead for 30% at low intensity, you can go for 80, even 90% at high intensity, but short duration. Now you're trying to build up resiliency in the tissue, set articulation of the joint. Okay, so you want to go low intensity, then you can go into high intensity as well. All right. What does that look like? That can look like you can actually start incorporating eccentrics and concentrics as well. So the low intensity is most likely isometrics. You could do low levels, but I usually stay isometric, low intensity. When I go high intensity, that's when I introduce concentric and eccentric as well as some isometrics as well at any range. Then you can go into speed strength. Now you have got this tissue to kind of understand to be still, be strong, be still, be strong in control, moving. Now you need it to be strong in a dynamic manner. Okay, so what does that look like? Low intensity can look like isometric grip strength. Okay, how long can you hold something in that low intensity? It doesn't have to be heavyweight. It could just be a can of soup that's not heavy. How long can you hold it? How long do you have that strength in your peripherals? Okay. High intensity can be, okay, now we're trying to lift up a gallon of milk jug or a can of paint or something like that and put on the cabinet. That's more high intensity. All right, now your muscles recruiting more. Speed strength can be anything between trying to get it up there fast or even walking. All right, so walking is speed strength as well. It has you have to be strong enough to push off to move forward, but you have to be able to move your legs fast enough to catch you from falling. That's another video as well. Okay, so you want to be able to incorporate these three things within your treatment plan for neuropathy patients. Okay, so the last one, I'm losing point. Okay, pain. How does pain influence your approach? Pain is always most likely going to be present with a neuropathy patient from either overuse or nerves growing back. You're going to have some type of discomfort, okay? One, you must ask them where their pain level is out, and your job is to not make it worse, okay? Keep it the same or even make it feel better, but don't make it worse. If you're making it worse, you're going down the wrong path. You need to pivot from your plan, okay? So how do I address a person that has particular pain neuropathy? Once again, isometrics, but this is very specific. I do in-range positional isometrics. I do in-range positional isometric. What does that mean? Okay, so here, so I have a shoulder, right? Say my shoulder hurts right here, all right? This is a really bad shoulder. It hurts right here, okay? So what I do is I go a little below it. I do isometric here. I get my muscles strong to get right here. And once I do, I try to position them to be able to hold it there, and then maybe go a little higher here, okay? And then maybe go a little higher here. I don't push them into the pain. I go right underneath the pain barrier, and I just do a bunch of isometrics, maybe low intensity in the beginning because there's pain. Low intensity to get the tissues used to it, and then we can start ramping up the duration of that exercise, and then we can work towards the strength of that exercise, okay? If it's too much for them, then you have to regress them to more passive stuff where you're not doing any shear force on the tissue, more stretching or manual therapy. Make sure you are able to do that. If you can't, refer out. It's no problem. You can bring them back. If they can handle it, then you start going more of the more aggressive stuff of concentric or more so eccentric as well. All right, so these are just little ideas of how I address people with neuropathy. It has been working for me. So leave your comments in below. Let me know how you like it. Let me know what you do for neuropathy. Did I miss something? Was I incorrect? Come on, let's have a conversation. Reach out to me and we can have one, okay? So this is just the beginning, first video of a series of medical conditions, and we talked about peripheral neuropathy, okay? I'll see you soon in the next video. I'm gonna have a lot more of that. This is a new thing I'm trying. I don't know, let me know if you like it, all right? Until then, I'll see you soon.